Hello and welcome to the Parent Survival Kit podcast, from surviving to thriving in your household. My name is Gene Schwalen. Next to me, as always, my beautiful bride, Dr. Sonia Schwalen, pediatric expert psychologist, nationally certified school psychologist, and we have a very special guest on the show today. We're so excited. So we have Dr. Stephanie Setliff. She is a psychiatrist, pediatric psychiatrist expert, and we're going to talk about medication, doping our kids up, getting them everything they need so they can actually act right and we can have a good life, and life is good. So
sounds good.
You going to talk to us about doping our kids up, Dr. Setliff? Why don't you tell the audience just a little bit about your background, just so they have the pleasure of hearing how awesome you are?
Well, I don't know if I'm that awesome, but I'll tell you what. I'm a child and adolescent psychiatrist, and I trained at UT Southwestern, and I ran their inpatient psychiatry program for years and developed an eating disorders program there. And right now, I'm at Eating Recovery Center. I opened our treatment center in July 2014, and we've grown and grown anyway. So now here we are in May 2021, and we treat eating disorders of all levels of care: inpatient, residential, partial hospital, intensive outpatient. We don't do outpatient work because we've got fabulous people like Dr. Schwalen who does. So that's what we do. That's my background. I love treating eating disorders, and in that, we do tons of talking about parenting, tons of talking about medication, and do a lot of referrals for family members, whether it's parents or siblings who need help from people like you.
Great. And thank you so much for taking time out of your busy day to be here with us today.
You're welcome.
All right. So let's talk about doping up our kids, right, Gene?
yeah, so I mean, as a dad, we've got 4 kids, and I've always been kind of scared to put my kids on medication. One of the fears I have is them getting addicted to some of the medication, or that being their lifeline. So can you speak to, should we have fears of addiction when it comes to medicating our kids?
Well, there are some medicines that are more prone for people to develop an addiction. But here's how I think about medicine for kids. I think about, you don't need it unless you do. So, and the younger the child is, the more likely they might respond to non-medication like alternatives. So there are all sorts of things that you can do for the kids that are under 10. Even when people have attention problems, there's different interventions than medication. So if you are scared of it, or you just have reservations, which I'm just like you, I'm a parent. I don't want my kid to be on medication unless I need them to be on one, because I also don't want them to not be successful at school, not be successful socially, feel like there's something wrong with them, inadequate. I don't want that either. So I think when you get to psychiatric medicine, I think child psychiatrists are really very good at prescribing. They prescribe prudently and, conservatively. But there are medications that make problems that children are having better. And when people, children, adolescents, are having a real interruption of their functioning, I think that we ought to look at it. So I'm not a pro medication psychiatrist, but I use it, and I'm happy to use it. Obviously, parents have to give consent for kids to be on medicine. So really, I spend a lot of time talking to parents about medicine.
Mm-hmm. Yeah, and that's one of your passions that I understand, is working with families and whatnot. So with the interventions that could be alternatively successful for kids, that could be without medication or potentially with medication. One thing that I've heard a lot of is that more times than not with kids, medication can be just like a small component of the overall treatment plan to really see great success.
Right. That is definitely the way to think about it. When I'm talking to families about it, I talk to them about a multi-lane highway, and that medicine is in one of the lanes, but it's certainly not the answer. There's individual therapy, there's education for parents, there's working with the schools, there's so many things. And so medicine is a tool. And if you use it that way, I think there's a place for it. I totally get it when people don't want to use medicine no matter what. They probably don't need a child psychiatrist then, because that's what we do.
That makes perfect sense.
I want to follow up with that, because a lot of times families will ask, if I do put my child on medication, does that mean they're going to be on it forever, or how long do they have to take it? How do you usually explain that to parents?
Yeah, I mean, what we say is it's very hard to predict the future. So forever is a particularly long time. But what I can say is with almost everything, including medication that isn't psychiatric, there's a risk and a benefit, right? And so you look at the risk and you look at the benefit and you look at them carefully because it matters. And if there is a slight risk of somebody being on a medicine, but the benefit is overwhelming. And I'm just thinking about a child that was the daughter of two physicians, and she was brought to me. It's a long story about why she was brought to me. It doesn't matter. But she was in 4th grade, and she was depressed, but her depression was really because she was being bullied. She was being bullied because she had these awkward things that she did that other children didn't do. When she got upset, she would pull her hair, or she would start like clawing on her arms, or clawing on the bottom of her legs. And when something happened on the playground, she would run over to the side of the playground and do some things by the fence that no other child did. So she had very poor coping strategies. She was vulnerable to being bullied, and she was bullied. So then that made her depressed and made her have school refusal, and she wasn't sleeping. So we used some psychiatric medicine for her because I sent her to therapy, but that's not going to happen as quickly. The results of that may not happen as quickly. So we put her on medicine, and honestly, when she came back to see me, 2 weeks later, she was already much better. She wasn't crying. The bullying had slowed down. Her behaviors, she was kind of being glued together. She had less anxiety. And she was on medicine for about 3 years. And one of the medicines has a little bit of risk to it, but really all you have to do is draw blood and make sure that their labs stay normal. And when what we were watching, cholesterol went up a little bit, I said to the parents, they're physicians, we should look at taking her off. This is something that is a side effect. And you know what they said? They said, no way. No way. We're not doing it. And they didn't. They said we'd rather treat the cholesterol in the short run. And obviously she'd been in therapy, so she's growing up. Her brain is developing. Time is on our side.
So they absolutely saw the benefit of it. It outweighed the risks for them.
Oh my gosh. Just beyond. They were so thrilled for her. I mean, they had tears in their eyes talking about it.
I like that you said glue together, because that I find that phrase is really helpful for parents to really think about it as a way to, because when I think about it as a psychologist and I'm thinking, this child is not getting any benefit from therapy right now because they're needing a little extra tool in the toolbox, right?
Right.
And that medication can give them the glue, I guess, right? Just what they need to feel better, enough to actually even get the benefit from a therapy session.
I agree. And we see that even with eating disorders, that they can't use their coping strategies because they're being faced with their phobia, the food, 6 times a day. Mm-hmm. So sometimes we have to use a little bit of medicine to help glue them together. And do they stay on it forever? No. The truth is, I've not looked at this in a chart review way, but I don't even, when I see my patients outpatient or they come back to see me later, nobody's really ever on the medicine necessarily that they were on when they were in crisis. Mm-hmm. They were in crisis, and so crisis calls for a different medicine than 2 years later when they're doing really well. They've been in therapy, they've been in family therapy, their brain is 2 years more mature, and we just can't forget that, brains fully, your prefrontal cortex fully comes online from 23 to 25, and nothing personal, but there is some argument that men may not always come online at all.
I agree with that. That's a very
I'm
good
okay
argument.
with that. I want to be a kid forever anyway, so.
So now you know what you're
I'm
saying. I'm going to ask the next question, and then I promise I'll let you ask the next few.
Uh-huh.
But, you're talking about child brain development, right? And so, what do you know, or what can you share with the parents about the concern that psychotropic medication interferes with brain development, or does it?
Well, we don't have any data that really suggests that. We, Now, the issue that we have as child psychiatrists is that most of what we do with psychotropic medication is off-label, right? Because drug companies pay $1 billion or more to get a drug FDA approved. They're not very likely, not that they never do, but they're not very likely to go back and get an indication for child and adolescent. So we have to be really thoughtful and use our clinical experience and expertise and consult with our peers. But my worry is what untreated depression does to a brain. Because we know that untreated depression will change a brain.
Okay.
And
so will an eating disorder.
And so will an eating disorder. So once again, it's just always risk versus benefit for me.
Okay.
Yeah, that makes sense. I mean, just from my business background, I teach on really 4 chambers of a person, spiritual, intellectual, physical, and emotional. And if you're not pumping all those chambers equally, you're going to be off track at some point in time. If you think of a ball and you roll it and it's not fielded properly, you're going to be off track. So a question I have as a parent, if I had some concerns about my kids and I wanted to bring them to a pediatric psychiatrist, what does that appointment look like? Like, how do you determine really, like, what are the procedures in that appointment to figure out what my child may need from a medication standpoint and what the benefit and also maybe the risks or that we should, weigh out?
Right. Well, what it can look like usually, honestly, is that there's not enough child psychiatrists in the country, so it's quite difficult to get into them. And I hate that, but it's just how it is. So you're not going to get in urgently right now usually, and that's why that psychologists and therapists are so important to be holding kids. But what it looks like is I think generally everybody goes in and talks to the child psychiatrist. Sometimes the parents go and have a meeting beforehand, and then the child comes to the next meeting. Sometimes the parent will meet with them for a bit. Then the child goes and meets with them for a bit. Then they all meet together. It can be different. It's really individual about what the psychiatrist's preference is. But what they really want to do is get a good history so that they can have a better understanding of what's happening and make a treatment plan. So, in some situations, it makes more sense. When it's an adolescent, the older the child, the longer the psychiatrist tends to stay with them. Child psychiatrists are really good at keeping things that, keeping confidentiality. And just because they met with the child for 30 minutes and they meet with the whole group 30 minutes, it doesn't mean that they don't know how to keep the things that the child told them that aren't relevant confidential. So they're just good at it. They're used to meeting with systems. So if your aunt lived with you, they'd want to meet her because it's all part of the system and it's where the child's living. And then they decide sometimes right away that they want to use medication. Sometimes they want to talk to the therapist. They want to talk to other people, the teacher. And that's really common that they gather information, especially if the child is under 10, before they approach a parent about medicine. If they do, they're giving you educated, thoughtful advice. I would suggest you take it.
So, Dr. Setliff, there's a myth maybe, because I think you just debunked it, that psychiatrists can only spend about 15 minutes with a client, and that's all you're going to get every 3 months.
Yeah, that's just not true.
I think that's a big fear out there. I hear it from parents all the time.
Yeah, it's just not true. That's just not true. Child psychiatrists will spend on whatever it takes to make sure that they're doing the right thing for the child. And I don't know every single one of them.
Yeah.
But if they had that problem with a child psychiatrist or any psychiatrist, my answer is change psychiatrists. Right?
Go shopping.
Right. If you have a realtor that isn't very kind or for some reason won't show your house, you change realtors. You don't decide you have to stay in your house for the rest of your life. Mm-hmm. No, you don't. You change realtors. It's the same. Not every child psychiatrist is going to do what I'm talking about, but we've got plenty in our town that will.
Okay. That's really good to hear.
Yeah, one thing that you said that stood out to me just with experience being around my smart wife over here who's way smarter than I am, because my brain is still developing and maybe never developed completely.
Smart,
Okay, I shouldn't even have said that.
He caught on though.
No,
so
I
quickly.
know.
Look,
Yeah,
But
he
she- but
caught
you-
on with
Give
the
him some
humor.
credit,
Yeah,
yeah.
yeah.
But you did talk about like different settings and looking into cross settings. My mom is our nanny. So if we had a problem with our 3-year-old, then we may need to talk to Mamaw to figure out, is she noticing something that is going on, or maybe something's not going on with her that we may be seeing in a different setting. So it makes perfect sense.
I mean, sure. And you might take her to one of the appointments and she might, the child psychiatrist might talk to her and her perspective might be different, right? Because there's your perspective and my perspective and the truth, right? And somewhere there, you have to make peace with all of it. And what they want is just to know enough to be able to help that child.
Okay. Well, you mentioned something earlier about there's not very many child and adolescent or pediatric and adolescent psychiatrists. So I have heard there's a lot of pediatricians prescribing medication. As a coach, I've mentored and coached a lot of kids from all ages, starting at 3, 4 years old, all the way up until high school. And there's a lot of parents that talk about their kids being ADHD. And even as a coach, we're like, well, my kid has ADHD, so if he's not paying attention or focusing, that's the reason why. Or he doesn't have the H, he just has ADD, and all those funny things that go on. But, they really want medication for their kids, or they're on medication. But one thing that I've heard also is that a lot of times there's prescribing medication for ADHD, and it may not even really be ADHD. Like, how much time needs to be spent, and how much, I guess, how many conversations need to happen or whatnot to really determine if someone really does have ADHD.
Right. There's rating scales for that, right? You give them to the parents, you give them to the teachers. And, you also interview the kid. But I think the thing with ADHD and medicine is, if ever there's a medicine that you have to be kind of thoughtful about, it's that medicine, in that it can really just, I would say, make their appetite totally go away during the day. So you have to have strategies for that. Feeding them a big breakfast, being ready to feed them lunch that's kind of right after school. There's workarounds, but you don't want their growth spurts to be affected, and you don't want their weight to be affected. So they have to stay on their growth curve. Now, if that's a real problem with a child, you don't take them off necessarily. It's not the ADHD medicine that's bad. It's that particular medicine is not a good fit for that child.
Okay.
But there's a bunch of others. So you just have to have psychological flexibility. It's no different than if an antibiotic wasn't working. You don't decide, oh, well, that infection's just going to have to stay there. You just change antibiotics, or you increase the dose, or you do something like that, right? It's not. So there's so many medicines right now for people for kids, adults with ADHD. I mean, I think you don't have to jump at the medicine. I think there's other strategies. And if a child is floundering in school because they can't focus and they can't concentrate and they're getting in trouble all the time and they can't bring their homework home, or if they do their homework at home, they can't remember to bring it back to school. There are just reasons that I think medicine makes sense. I don't really have a dog in the fight. I just think that there's reasons that medicine makes sense, but it's really a parent's choice. They decide what they're going to do.
I just want to share this, and this is I'm going to do a little shout out to people out there in the real world. So I'm going to tell them to watch this episode, but this is for you, Dr. K, Dr. Meyer, Tiffany, and Katina. I co-authored a paper in grad school, Psychotropic Medications, What School Psychologists Need to Know. And what we did was we looked at what the medications were FDA approved for, and then how psychiatrists prescribe off-label, as you mentioned earlier. And just for y'all out there that don't understand what that means, it's prescribing a medication, not what it's FDA approved for, but more for what, from experience, y'all understand how you can use that medication, right?
Right.
And so what we did was statistical significant differences between head-to-head comparisons of side effects of those medications. So what you're saying is, with a stimulant medication, if you knew, this one is more statistically significantly known to have, decreased appetite as a side effect versus this one or that one, would that data be helpful to somebody like you? So I have to share that with you. I just wanted to say that, do the shout out.
Yeah, for sure. And
paper that would be cool to share with you and talk about.
I think it'd be awesome to see. And you're right. There definitely are some that we kind of know. They're like known offenders. They're really good. But sometimes the risk isn't worth the benefit. If there's another medicine that doesn't make them lose their appetite and provides the same benefit.
So side effects is another common question that parents are concerned about and really think about. I think we mentioned earlier, like, what if it changes, the child's personality, or what are some common side effects, and how do you determine if something is intolerable and you need to make a change, or if it's just something that they have to ride out?
Well, I'm not a big fan of just accommodating the side effects, right? Now, when people first start the medicine, child psychiatrists, I know that adult psychiatrists do it too. We know that if you start low on maybe below the starting dose, especially a dose for a kid that you would normally give, I'm just thinking about Zoloft, a normal adult dose, you might start them at 50 milligrams. With an adolescent, you might start them at 25. With a little kid, you might start them at 12.5. You see what I mean? So I can mitigate a lot of the side effects by how you start. So I like to do that when possible, and especially anxious people. They're anxious about everything, so why wouldn't they be anxious about their medicine? Mm-hmm. I tell them that all the time. They'll say, I'm so anxious about starting the medicine. I'll say, of course you are. You're anxious.
Why you presented for treatment in the first place.
Right. That's why you're going to go on medication.
Right. But why wouldn't you be anxious about your medicine? And so we try to mitigate that way. The different medicines have different side effects that, usually they will go away. Like there might be a headache, or there might be a little bit of a stomachache, a little bit of nausea. Now those kinds of things, a lot of them, it'll go away over the first week or so. But I don't subscribe to, sometimes they'll say, well, I'm feeling better and I don't really mind the nausea. I'm like, no, we're going to find a medicine that makes you feel better without the nausea, right? Okay. The things that I worry about with ADHD medicine is, tics. That's kind of a common side effect. And really you just have to stop that medicine. Now, there are other medicines, as you know, that are not stimulants, that are not nearly as likely to cause tics, that do work well in ADHD. And so that's what we go to.
So you're constantly balancing all of that. It's like my professor always used to say, whenever medicine is being prescribed, it's like an experiment with an N of 1. And so you're just...
Absolutely. I think that's just absolutely true. And, people say to me, well, if you ever use benzodiazepines, aren't they going to abuse it all? Sure, somebody might, but anxious people don't want to take their medicine. And one of the ways that you can always tell when somebody is anxious is that when you say they come to see you a month later and you say, hey, do you need a refill on your medicine? And they say, no, I've got plenty. They're not taking it because they're anxious. So we have to say to them, no, I want you to take that medicine. Well, and then they'll say to me, well, I'm trying to figure out when I get anxious, I'm trying to decide if I want to take it, if I need to take it. No, I've already decided that. So that's one of the ways that you tell. Like they start cutting their medicine, and you look in the bottle, and it's just a white powder at the bottom.
Oh, they're breaking it in half and whatnot. I'm going to take half a dose. Yeah.
Totally.
So one of the questions I have as a parent would be side effects. All right, so first week or two, you kind of just monitor it. If it's nothing too extreme, just monitor it and whatnot, see if you get through it. How often do we need to come back, especially in the beginning, to really kind of check to see how things are going, progressing, and all that?
Yeah, when we first start medicine and outpatient, I have the luxury of a treatment center where people are there all the time. But when we first start medicine, we need to see them within the first week or two. Like definitely they come back within 2 weeks, and then we talk to the parents about all the things that they need to be watching for. A really big issue with psychotropic medicine and antidepressants is that there is a chance that it will cause suicidal thoughts, spontaneous suicidal thoughts. It's always been that way, but antidepressants got a black box for kids years ago. So we have to talk about it. That's the thing that you really talk about. It's kind of like a collaboration with the child and the parents. If you start an antidepressant and we say to them, if you have suicidal thoughts. It's important that you don't get scared of it. You don't decide you're going to try to handle it yourself. You have to go right to your parents, and they'll call me, and we'll decide what to do. The thing that makes it a little bit difficult and challenging is that depressed people also have suicidal thoughts.
Yeah.
So you have to weigh the risk and the benefit, not to just sound like I'm beating a dead horse, but you have to decide, is this something that we're going to watch carefully? Is this something that we're going to stop the medicine immediately? They've had them before. So is this one because of the medicine, or is this one because of a grade she just got? I mean, so it's a little bit complicated, but it's just what we do, right, for a living. And I mean, other people do. You do things for a living, and you're good at it. And so I think child psychiatrists, for the most part, are used to talking to kids and parents about the possibility of suicidality.
Yeah, and one thing that I've heard before is like when my kid is on medication and now he's like on this cocktail straitjacket. He's just like kind of like a zombie and whatnot. Is that the medication, or is it just maybe just the wrong medication, as you mentioned?
Yeah, I would say it's not working. Right? It's the same thing. I mean, that's not working. That's not who the child is.
He's nice and calm now, but now he's just not himself either, and that's not working.
Right. And you have to go back, and you really have to advocate. This is true about medicine in general, right? This isn't just about child psychiatry or psychiatry. You have to go back and advocate for what you need and what you want, and that's how you get the best result.
I'm just so excited that you said that, because so many times clients will sit back and fail to be an active participant in their own treatment. And they generally will come out of an appointment with a provider and say something like, oh, well, they're saying I need this now. They're wanting me to do that or this, right? And they're not really doing that advocacy for themselves. Mm-hmm. They're not taking that assertive role in their own treatment of what maybe is working for them, what's not working for them.
Totally. I get I smile and talk about this with my patients and their families. If you can't be honest with your psychiatrist, I mean, who are you going to be honest with, right? I mean, you've got to tell the psychiatrist.
That's what my attorney tells me.
Well, there's truth in that. And that's the same thing about therapists. I'll say, have you told your therapist that? Oh, no, I haven't told her. Well, how long have you been seeing her? 3 years? Oh, my God. So I think sometimes our families, our parents they don't want to rock the boat. They like the psychiatrist. They don't want to upset the psychiatrist and say, hey, I don't like this medicine. My son isn't who I know. Like, the medicine is making his behavior a little bit better, but this isn't him. They don't want to challenge it. But, people that are in my field that are really good, they of course they want to know. They're not taking that personal. They didn't
develop the medication.
No, they're just going to say, oh my gosh, we've got to do something differently. I only met your child this way. I didn't know that there's another way. You know your child better than I do. We don't want that. No, there's no child psychiatrist I've ever met that said, I want to make that child a zombie, and definitely not like he was. No, that is not right. We want the child to be the best version of themselves.
Sounds like
that.
Yes, absolutely. There's a lot of things I see on Facebook from parents, and like their kid is acting up. They can't take it. They want to have some Calgon or something. They want to, jump off the cliff, and they just want their kids. I need some medication for my kids. Can you help me out and whatnot? I think what you said earlier about settings and whatnot, it's not just the medication though. We as parents also play a part in that. And there's a job to be done. So even if we put our kids on medication, we still have a big part in really how that all plays out.
Yeah, I think so. It's just one lane and a big multi-lane highway, right? I mean, kids for the most part want structure, limits, and consistency. That's what they want. Mm-hmm. It's very low tech. They need to go to bed at the same time. They need to get up at the same time. Sometimes it's annoying for adults, right? Yeah. But they really just need structure, limits, and consistency. And I'm just talking about the bell curve of children that have just normal
normal functioning. Yeah. Exactly.
Yeah. I mean, obviously they're different.
So our jobs are pretty easy. Just get them up, feed them, put them to bed on time, and we're good.
Do the same thing every day.
No screen time. Don't put them in front of the TV as a babysitter.
Right.
So I do have.
And then make sure your providers are working as a team. I always say
that's exactly true.
It takes a village with kids, right?
Right. That's
why we refer to each other and we work together and we value each other's opinions.
That's exactly right. And when we're referring out for our patients to leave treatment and they don't have a team, the therapist will say to me all the time, Dr. Setliff, where do you want to send the patient for psychiatry, for medication management? And I always say to them, ask the therapist who they work with, because that's going to be the best care. It's
a team.
It's the team that knows each other, that's used to working together. That's always going to be the best care.
There's communication, collaboration, and all that.
Yeah.
So I really appreciate your time. I got a couple of other really quick questions.
Yeah.
So you mentioned like the example of the kid, the fourth grader with the two parents who were physicians and whatnot. I know a lot of parents who are completely against medication. They're against getting their kids the shots and whatnot when they're young, but they believe in essential oils. What are your thoughts on essential oils, the cure-all?
Well, I really like essential oils. I mean, I do. I think they're fabulous. I think they work a lot in meditation, and I think they can relieve stress, and I like how they smell. And some of them are edible. I just don't have any data that says that they treat major mental illness. I don't have any data that says that that's going to work. I'm not against them, though. I'm really a fan of alternative medicine, honestly. I just think sometimes you need to combine it with Western medicine for the best outcome.
Yeah, that makes perfect sense. Well, I know before the show we were talking about CBD and all that too, and you talked about this big dog section. Is there like a kids section at CBD?
You know what? I've never seen it. I've never seen it. I've never seen what they say about CBD and kids. Funny enough, I just saw a huge section about dogs, though.
Yeah,
that is interesting.
That was
That's a good
interesting.
point.
So that's I was waiting to ask this question because I know when you said that, I was like, I wonder if they offer this for kids, because you talked about it. Does it do work for this? Yes.
Yeah.
Absolutely.
Yeah.
Hands down. Right. Once in the morning and twice in the evening, right?
That's right. Anxiety, tennis elbow. I've got friends that swear by CBD. So I just am not an expert in it, and I can't really comment on it. I'm sure if it worked to decrease kids' hyperactivity, that there'd be a line out the door for it. But I don't know.
Well, there's a lot of movie stars and actors that swear by these different diets too, and they advertise them. And I've tried them; they never did work. I never looked like that. So,
Let's talk about diet culture on another episode, right?
Right. Diet culture would be a fun thing to
that
talk
would be
about.
fun.
Yeah, but thanks for all those questions. I really am a fan of alternative medicine. I went to see a acupuncturist once, and I said, I got problems with my back. He said, no problem. And I said, well, I've gone to my Western doctors, and they don't seem to be able to help me. He said, Dr. Setliff, Western medicine has had medication for 200 years. We have had medication for 3,000 years.
That's awesome. That is awesome.
He said, I'm going to take care of your back. And so, I'm a big fan.
Well, do you have any other questions, Dr. Schwalen?
No, I love that you came on today. I really appreciate it.
This was lots and lots of fun. So great information. I know the parents are going to love this too. So we look forward to having you on again. So
thank you so much. It was fun to be here.
Well, thanks for joining the Parents of Advocate podcast. We'll see you next week. Stay tuned.